Okay, great. So I think we're going to start. So my name's Adrian Basker. I'm the chair of the IAA's health section. Welcome to our webinar on modelling COVID. For many that are regular attendees of IAA webinars, this one is a little bit different to those. It's a collaborative effort between the IAA sections, and as I said, I'm the chair of the health section, but this is open to all section members, not just health section. So it's hosted by the 6 sections of the IAA, which are the health section, the life section, the pension benefit and social security section, the consulting actuaries section, IARCA, the Aston section, which is actuarial studies in non-life insurance, and the AFIR ERM section on financial risks and enterprise risk management. For those that are attending this and it's your first introduction to IAA type webinars, there's a regular program of webinars that we run throughout the year. All section members can attend, and joining a section is easy if you just go to the IAA website. We're doing this in collaboration with NOCA, and our moderator Rulof will talk a little bit more about NOCA. And we're proud to host the C19 Actuaries Response Group, which has an interesting history. It's less than 9 months old. And again, we'll let Rulof talk a little bit more about the C19 ARG. So if we can go to the next slide. Which I'm not seeing on. Thanks, Louis. So just to say, in this partnership between NOCA, the IA, and the Actuaries Response Group, we're intending to do some further sessions on COVID. It's a massive topic. It's dominated many of our lives for the best part of 2020, and there will be a lot of lessons to be learned from this. And the next one was scheduled for later in December. It will be on living with COVID, which will be getting to the next normal, or the new normal, from a medical, community, workplace, and economic perspective. So please look out for announcements on that one. But without further ado, over to Rulof to talk about today's session.
I am a co-founder and ex-president of NOCA that Adrian was referring to. NOCA is the network of consulting actuaries, and we're predominantly focused on providing high quality CPD every last Friday of the month. If you're interested, head over to noca.uk, noca.uk. Today, though, is all about the C19 Actuarial Response Group. And as Adrian said, this is the first of a series of sessions that we're going to be doing. Today's session focuses on modeling, and we're looking forward to getting your questions. I'll remind you again, but please use the question and answer functionality on Zoom, and then we'll get to as many of them at the end as we can. Today's session focuses on lessons learned and how we can move forward. And I think this is an area that actuaries can really play a big part in. We're intrinsically trained to use the past to predict the future. And if there's any lessons we can learn from this volatile past that we've had this year, I think we should be sharing those and improving going forward. For those not familiar with the Actuarial Response Group, as Adrian said, they started in March and they've rapidly grown. They keep publishing excellent high quality output, bringing professionalism and good insight, good communications to all of them. I can not recommend enough getting to read them every week when they come out. At the moment, they're at over 80 publications and growing. So please keep looking out for them and support them. I'm going to hand over to the experts because I work in climate change and this is not my area of expertise. And with that, yeah, Matthew, if you'd like to take us away.
So thank you. I'm Matt Fletcher. I'm a senior consultant with Aon, working in our Demographic Horizons team. So we provide advice on mortality and longevity to pension schemes and insurers, reinsurers. I also chair the CMI SAPS committee, which produces the UK's industry standard pension scheme mortality tables. And yeah, as the title of my section suggests, I'm going to try and look at what we've learned from the data coming out from the COVID-19 pandemic, and then we're going to look later about how we model that. So we move to the next slide. So in general, I'm not going to focus on the absolute numbers because obviously they're different from country to country. I'm going to focus more on the principles and the potential pitfalls that needed to and still need to be looked out for when considering the data. So this picture is a very simplified life cycle of COVID-19. So you start off with a healthy individual or someone who's not infected with COVID-19, may have other health issues, but they get infected. Hopefully they will recover, but if not, they may end up being hospitalized. Again, hopefully someone who does end up being hospitalized with COVID-19 will also recover, but of course we do know, unfortunately, that some will die. And from a modeling perspective, the key areas really where we would focus typically would be the transition from healthy to infected, and then the transition from infection towards death, as this allows us to estimate how the disease is spreading and how fatal it is, as well as whether and how any interventions that are put in place are helping to slow the spread of the disease. It is helpful, though, to know about hospitalisation as well, so the intermediate step, both from the point of view of estimating the likely burden of the disease on a country's healthcare systems. So if hospitals are completely overwhelmed, then death rates both from COVID-19 and from other causes are likely to increase significantly. But also when trying to estimate the future burden of morbidity and mortality. So I'm talking there about whether those people who are hospitalized have higher future healthcare needs than they would otherwise have done. In theory, it should be fairly simple to get information about most, if not all, of these stages, both on a national and subnational basis in many countries in the world. But in practice, through the pandemic, it hasn't been as simple as that. So I was going to walk through each of the main stages in turn. My examples are mainly UK based because that's my area of knowledge and practice, but I do know that similar issues have been relevant in other countries, and I'll mention a few as I go through. So let's first look at infections. We go to the next slide. So we count an infection as an individual who is or has been infected with SARS-CoV-2, which is the virus that causes COVID-19. By contrast, a case is someone who is or is at least thought to be infected and has received a positive test. So typically there will be far more infections than there are cases because we don't test everyone who is infected with COVID-19. This distinction is key, particularly because of what has happened over the year. So there's been a large change in testing practices in many countries, including the UK. The number of cases being picked up, as you can see from the small chart to the bottom, which is the actual data, the number of cases in the second wave is much higher than it was in the first wave. That doesn't necessarily mean that the number of infections is higher. The number of tests carried out may well have gone up even more quickly. So for example, in the UK, at the start of the first wave, the only tests that carried out were in hospital, total infections. And this is also likely to be why the age structure of cases was very different in the first wave than the second wave. Because older people are much more likely to be hospitalized and therefore more likely to be picked up in that first wave of infection, where later on when we have a more comprehensive testing regime, more younger people are likely to be picked up as being cases. Go to the next slide. So there are a number of ways to estimate the proportions that are infected with SARS-CoV-2, and each of these do slightly different jobs. So firstly, we have surveillance testing. This is a way to estimate the proportion of the population who are currently infected. And this is helpful both to monitor the spread of the disease in a country as a whole, and also to consider whether or when it might be appropriate to think about more targeted approaches to hotspots of infection. In the UK, this is done by the Office for National Statistics, who have a COVID-19 infection survey, and essentially randomly selected households are asked to carry out swab tests, and there have been 150,000 households targeted in this way in recent months. There are similar efforts going on elsewhere in the world. And the ONS, their latest estimate is that somewhat over 1 in 100 people in England are currently infected, and the numbers are somewhat lower in the rest of the UK generally. So the second is serology testing. So this tests the level of antibodies that are in the blood, and these tests are essentially designed to estimate the proportions of the tested population who have ever been infected, so not just those who are currently infected. And this is useful when considering the speed of spread of the infection, as well as estimating the proportion of the population who may have immunity to future infection, whether total or partial. And then the third is community testing. So the results from community testing are the proportion infected of those who requested a test. So the results from this are typically give you much higher positivity rates than the surveillance tests, because the sample is not random and typically is self-selecting from those who are likely to be infected. So either because they have had symptoms, or because they're at higher risk due to their job or due to being in contact with an infected person. These results are still useful because firstly, they give an estimate of the level of infection overall, plus in regions of a country that may have higher infection rates. Also, if positivity levels in community testing are very high, that suggests that not enough testing is being done, because you wouldn't expect necessarily for a large proportion of people to test positive. You do need to be very careful with all of these figures. So firstly, that your population hasn't been either deliberately or accidentally selected to have a much higher or lower level of infection than the overall population. So for example, if you do a serology test on healthcare workers, you might expect to get a very high result because they're more likely to have been infected, or at least exposed to infection as part of their job. You also, there's some concern, so with all tests there is some level of false positives. So false positives being those who test positive who aren't actually infected, and also false negatives, which is those testing negative who are infected. For most tests that are currently being used, the false positive rate is very low, and we've written a paper on this, setting out the sorts of numbers that we're talking about here. But there is some concern that newer and quicker tests, so these tests that where you can get the results within 15 minutes, may well have slightly higher levels of false positive rates, but potentially more concerning is when they're used in the field, they have quite high levels, look to have quite high levels of false negatives. So people who are actually infected being told that they're not. There's also some suggestion that serology studies may actually underestimate the total level of infection, because negative tests may not reliably exclude prior infection. This is because, especially if you're testing asymptomatic people, they may not have had a high level of antibodies in the blood anyway, and if you test them a long time after they were infected, the levels may not exceed the positivity threshold. And finally here, you also need to look at data report. So sometimes large numbers of tests are changed much, And so in the UK, concern on the more recent tests. So we can move briefly on to hospitalisation on the next slide. So in hospitals, individuals will usually be tested for COVID-19 infection when they're admitted to make sure that other people in the hospital aren't infected. There has been a lot of discussion as to whether, hopefully, can people hear me okay? So, okay, I should try turning off my video, I apologize. Okay. So there's been a lot of discussion as to whether hospitalisation figures are with COVID-19 or because of COVID-19. That is, whether a hospitalisation for a totally different cause is treated as COVID-19 due to a positive test. We find that the hospitalisation figures are generally consistent within countries, but when comparing between countries, you do need to be certain that the level of care is consistent and that admission criteria are also consistent. For example, some countries are less likely to provide mechanical ventilation than others, and some may either need to because of capacity constraints or choose to provide particular treatments to the oldest in the population. So if we move finally on to deaths. Again, in theory, this is easy because you just count the number of deaths that have occurred, but in practice, it's much harder. In particular, what exactly does a COVID-19 death mean? And we could do a whole session just on the different ways of recording deaths in the UK over the period of the pandemic. But in particular, so to start with, during the initial weeks of the pandemic, the only deaths that were recorded as COVID-19 deaths in the UK were the hospital deaths where they'd had a positive test. That was then, the scope was then increased to take account of care homes, and the numbers of deaths went up significantly. There's also, in the Office for National Statistics data, you don't actually need a positive test and never have done. It's been whether COVID-19 has been recorded on the certificate as a cause of death. And there's also a question about the time after a positive test as to which a COVID-19 death is recorded, assuming that there is a positivity requirement. Again, in the UK, there was a concern that if you had ever a positive test, then your death would be treated as a COVID-19 death, regardless of what the actual cause of death was. So the figures that are now published are deaths within 28 days of a positive test. There are other considerations. So, for example, date recorded versus date of occurrence can be quite different, especially when you're doing day-to-day figures. There are effects coming through, different effects with weekends and bank holidays, and potentially also different recording protocols. This is one area where another country, Spain, had a strange or a very different recording protocol that they changed at some point through the period where they started reporting 0 deaths in the whole of Spain, when actually there were 2 or 3 deaths coming through from COVID-19 just in Madrid. So again, it's difficult there on the deaths to be sure that when you're recording a COVID-19 death that you have consistency over time, and also between different countries. They may well have very different ways of recording things. So the statistic that we tend to use, if we move on, is excess deaths. So regardless of cause, this is the main metric that we're using and have been since fairly early on. So that's much harder to have concerns about recording practices and so forth, because that is simply a case of counting deaths when they occur. This data here is looking at England and Wales and by date of report. So other countries will have different reporting lags, reporting delays, which people would need to be aware of when even looking at excess deaths. As well, you do need to, if you're talking about how many excess deaths there have been, there are issues as to what baseline you might use. So here we've got a 5-year baseline. We're comparing weekly deaths. I've been asked for 10 years, 20 years. Someone recently on Twitter asked me to produce a 100-year comparison, which I thought wasn't a particularly sensible thing to do. And the left-hand one is not age adjusted. The right-hand one is adjusted for both age and population size. And again, when you're comparing countries, it makes sense to do that adjustment. Otherwise, you end up not comparing like with like. And then my very final slide, and hopefully it's come across okay more recently, is it doesn't quite fit with the overall life cycle theme, but it's still a data item of interest, which is mobility in different countries. So here you can see Canada on the left and South Africa on the right, and it's shown. Interestingly, South Africa had a big spike very shortly before the lockdown, presumably because it was well trailed and people wanted to get out and do things before they had to stay at home. And you can also see a significant increase more recently in mobility as restrictions have, and hopefully that came across okay in the end. Thank you.
Excellent. Okay, thanks, Matt. I hope I'm audible, am I, and so on?
Yes, Matt. We can.
Great, thanks. Thank you. So thanks, Matt. So my name's Matthew Edwards. I'm actually a former colleague of Matt and potentially also a future colleague with the Aon Willis Towers Watson event. So my day job is Willis Towers Watson, work in the life practice, the UK insurance and consulting technology team on the life side, where I'm the proposition and innovation lead, and generally sort of been leading on all things to do with mortality and longevity and so on. I've also, as well as the COVID-19 ARG activity, also got some other sort of Institute and Faculty of Actuaries activities, so maybe it'd be interesting to touch on those at the end if we have time, and to publish some of the other, or publicise some of the other good things we've been doing, which may be of interest to many of you. So this section, I wanted to talk about model parameters and try not to overlap with Matt. Hopefully I'll be sort of taking off nicely from where he's got to, with particular regard to infection fatality rate, and then some of the aspects of risk factors, and not talking at all about the R parameter, the spread, and so on, which I think Louis is going to touch on in a decent degree of detail. And then at the end, sort of talk about other aspects of modelling, which perhaps we should be sort of thinking more about now. So moving on to the next slide, please, Louis, thanks. Great, so infection fatality rate. So as Matt outlined, talking about the risk of death here among all infected individuals, as opposed to sort of confirmed sort of hospitalisation type cases. And clearly trying to calculate the IFR, the infection fatality rate, is incredibly tricky, as it boils down, if you're sort of super cynical, and I guess we all need to be fairly cynical about many of the numbers we're producing, especially early on. It's trying to solve that equation down in the bottom left. Numerator and denominator are both highly uncertain, and certainly trying to do all this back in March, extremely sort of uncertain. So numerator, obviously deaths, denominator, how many infected people, both very uncertain. And there's also this whole question of the time lag from time of infection to time of death, because there's no point, again, more of an issue back in March, maybe when things were taking off. There's no point comparing sort of death today with infections today, because your sort of deaths are only going to come for people who would have been infected, several weeks before. So a large number of uncertain aspects. Back in early April, I think it's me and Matt actually wrote one of our bulletins on trying to calculate the IFR one of the themes of this, or I guess maybe the main sort of theme of this presentation is all about what have we learned, what's different now compared with when things were sort of kicking off back in March, April. And one of the surprising things about the IFR is that things have actually seemed to have moved relatively little in terms of our sort of estimates or our knowledge. So I think the bulletin we wrote, Matt and I, we were coming up with a figure a bit above 1%, and the latest estimates would be all more towards the sort of 0.5 to 1% range. So things have moved down a bit, but there's been no massive shift in thinking, to be honest. So what you got on the right of the slide is sort of references to sort of three fairly sort of reputable ways of looking at things. The top one, the Cambridge biostats unit, is always full of good stuff, and they've sort of popularised this word I find quite interesting, nowcasting, which does sort of bring to mind the fact that even just trying to sort of estimate what's happening today is itself a form of forecasting due to the way things work. There's a New York study in the Lancet recently, and the Imperial College has generally been a useful source of interesting stuff. So the table at the bottom is summarising those, and just a couple of words on that. So the all ages estimates in the top row. So if you sort of think about how an IFR works, clearly it's going to be very dependent for a particular country on the age distribution of that country, and a sort of developed country with a high average age is going to have a higher IFR than a sort of demographically younger country. So the reason you've got those ranges in the top row for Imperial is because they're actually presenting their results, that the 0.5 to 1% is across a range of possible sort of country demographies. But the interesting thing there, the range is of the order of 0.5 to 1%. New York study is a bit higher. And the various other studies all coming out with similar numbers. That the most recent Imperial College study with particular reference to UK, which they've been using in the projections, is I think 0.76%, or if it's not, something very close. There's probably one reasonably well-known study, the Stanford study, which came out over the summer, trying to argue for an IFR of down towards 0.2%, which we sort of again put out a bulletin on, sort of arguing against that. But the overall sort of consensus is in that 0.5 to 1% range. And again, thinking about that, it sort of almost takes us back to how the COVID-19 Actuaries response group got going back in very early March. I remember a call with Stuart, and Stuart was more of an initiator of all this than I was, to his credit. And we were just discussing how things were likely to develop, and if you got an IFR of the order of 1%, because that was the information that was coming out of China at the time, if you take a 1% IFR and you apply it to something very, very contagious, which we knew it was, then it means pretty much you're going to have, getting towards 1% of the country, a risk of death. Well, not a risk of death, probably dying, which basically means sort of doubling the mortality rate for a country such as the UK, at which point we realised that we really needed to try and get things going within the actuarial community. And it is quite surprising that those early estimates haven't really changed much. The age bands there, again, sort of tie no doubt with what you know about the sort of age pattern of COVID. I'm not going to talk much more about age. I think Stuart's got quite a nice graph later on about how COVID-19 mortality compares with the normal mortality. And just note the right-hand column, the Imperial estimates aren't there as sort of massive confidence intervals. It's more because they split their work into sort of tighter age bands. So the ranges there are from the start to the end of each broad age band, as opposed to the Cambridge and New York, looking at those slightly wider bands. But hopefully that gives you an idea of where we are now, and the fact that it doesn't really feel like we're a million miles from what we were thinking 6 months ago. Next slide, please. Thanks. So we sort of thought a lot about IFR back in April, and sort of must admit I haven't been thinking about it much other than just tracking what's been going on, and it doesn't seem to have moved much. So the other sort of big thing that started happening in terms of research and data and our own thinking within the ARG was around sort of what we could discern about risk factors. And I think it's useful talking about risk factors in a COVID-19 perspective, to sort of have the split between the two stages of morbidity, going from, if you like, from infection into hospitalisation, then mortality from either from hospitalisation to death, or from confirmed case to death. And this slide on the left shows one of the first studies coming out, and back in April. I think there are very few studies. So you're seeing there the odds ratios, and hopefully you're all quite familiar with how this sort of things work. So it's showing that if you're diabetic, then your chance of being hospitalised with COVID-19 for one of those New York patients is 2.8 times what it would have been if you were not diabetic, but all other things being equal, because it's a multifactorial study. So you see there's the gender effect, the diabetes effect. So I think it's one of the first times we saw a proper figure coming out for that. Obesity, so similar order of magnitude to the diabetes effect. And hypertension, I've put there in square brackets because I mean the 1.2 was the best estimate, but is also not significant, so hence the square brackets. But the reason I put it in the table at all was this is one of the first times we actually saw some proper multi-factor analysis. And previously, back in March, everyone had been sort of dredging the data for sort of one-way univariate analyses and saying, well, everyone's got hypertension, so that must be one of the big factors there. And clearly, given that it's very much an old person's risk, most of the deaths being in the sort of 70s to 80s, pretty much all of those people have hypertension. So the fact that you've got hypertension isn't necessarily itself a sort of substantial risk factor. It's more just restating the fact that you're old. So it's actually quite reassuring to sort of realise that when you do the proper study, the proper multifactorial study, that sort of dies away as if like an independent risk factor. And it's also one of the first studies to sort of have a good look at ethnicity, and we'll see that in quite a few of the other tables. So things looking sort of fairly materially above 1 for some of the sort of the BAME subsets, and that particular study also has slightly interesting results around tobacco, which have also been come out as sort of interesting, shall we say, in some of the other studies. So one of the first studies there on the morbidity aspect, on mortality on the right, so going from cases to deaths in the UK. So fairly good data, so 130,000 cases, confirmed COVID-19 cases, getting on for 30,000 deaths. And they're sort of looking more at ethnicity, region and deprivation effects there. And again, you can see some fairly material, although not overwhelming, impacts there for sort of BAME, Indian, Chinese effects. And the regional effects were fairly small in that, I think, due to sort of allowing elsewhere for some of the sort of deprivation. So that's what I wanted to say on those slides. Move to the next slide, please. So probably one of the best known studies from a multifactorial aspect is this open safety study from the UK. So again, apologies for having a bit of a UK preponderance here. So that was starting with electronic health records of around about 17 million people from primary care data sets, and tying those in with what deaths were known at the time. This was fairly early on, because you can see we were looking at 11,000 deaths. I think it was towards the end of April that the cutoff was done. So I suppose one sort of disappointing thing is that it hasn't been refreshed, because it would be nice to sort of have a more powerful study and have many more deaths feeding into that data, but there's been no update along those lines yet. But anyway, that's a very useful study. It's also combining both the morbidity and the mortality, because those electronic health records are sort of all people known to the primary care sector, and going from them to death, so covering both the morbidity and the mortality transitions, if you like. So obesity, very sort of severe obesity effects for these sort of BMI 40 plus types, and lower but still obese BMI, still quite material. Socioeconomic, so we've got quintiles here. So IMD, if you're not familiar with the UK classification, is index of multiple deprivation. So you'll know that we in England are sort of obsessed with our class system. So you've got 5 classes here. So 1 being sort of typically what's referred to as sort of most affluent or most white collar, and 5 being the sort of the least affluent or most deprived. And this is showing almost a doubling across that range, from high to low, or low to high. Ethnicity, sort of broadly similar results to what we've seen before. Again, also fairly material and bad if you're in the non-white part of the population. So some interesting results then from other medical conditions. So heart disease, cancer actually somewhat surprisingly low, but diabetes actually could be much higher, which again ties in with many of the other studies around diabetes. Hypertension, as before, no material effect, and some mixed effects from smoking. So I don't sort of just spend all my time just talking through individual figures. It's more interesting to sort of think through, well, given that knowledge, what can we usefully do with that knowledge? And we've been doing a few things, one of which we put out a bulletin on, and apologies for not being able to remember the number of the bulletin, but it's one of our sort of mortality ones, where we sort of thought through, if you have this information about risk factors for COVID-19 deaths, we can say, within a given insurance portfolio, if you've had a certain number of COVID-19 deaths, then you can use this information to work out that on average they were sort of somewhat more obese, diabetic, etc., somewhat more unhealthy than your average portfolio member, and therefore you can work out effectively the impact on the mortality of the survivor portfolio by allowing for the fact that a certain number of your portfolio have died with COVID-19, but they had already had unusually above average sort of all-cause mortality. So that's one sort of useful thing to do. I mean, the overall results from doing that tend to be only borderline material so far, given the number of COVID-19 deaths in many countries has been relatively low due to the non-pharmaceutical interventions and so on. So that's one thing. Another thing we were able to do, and I think Stuart's going to touch on this in more detail later on, is have a think about what does a typical COVID-19 death look like, in the sense that back in April there's quite a lot of news, or not so much news as noise, in the newspapers about COVID-19 deaths being a sort of at death's door, on death row, and therefore we could ignore everything because they're only sort of losing a few months of life, and we're able to sort of use information like this to sort of think through, well, actually although they might be a bit more obese / diabetic, a bit older than usual, they still got, you know, many years of life left if you do the calculations, and Stuart's going to go into a bit more detail on that. So that's the sort of thing we can usefully do with that information. The next slide, if we could move on, please. Next slide looks at the socioeconomic and ethnic aspects, looking at some other sort of studies that have been done. Because as these studies start to emerge, even as the one-way studies were done, it became more and more apparent that there was quite a big socioeconomic effect, and there's more and more concern about both that and also the ethnicity impacts of various other studies done. I won't go into detail on those on the left, but other than to say that if you're not familiar with the Biobank in the UK, it's a very, very useful sort of source of data, or rather source of research done on what to us is inaccessible data. So Biobank is a group of around 500,000 people, I think broadly in the age range 40 to 70, who've volunteered to be tracked and provided huge amounts of information to medical researchers, and there's always lots of interesting research going on with that database. And this particular study by Batty, which I think is not very well known, looked at that database with particular regard to the socioeconomic dimension here, and then rather annoyingly, it's one of the few studies which doesn't use the standard sort of IMDs 1 to 5. It's got a sort of a 3-tiered system, but again, it's coming out with quite a high sort of blue collar impact compared with the other end of their sort of, they've got their sort of 3-tiered class system, and more sort of ethnicity stuff again from a different UK Biobank study, again sort of similar results coming out. So those on the left. On the right, one thing that's been a great source of information is the ICNARC studies. So probably get the acronym wrong, but the first 2 letters stand for intensive care. So it's the group which we've been sort of looking at a lot, and I think Stuart and one of our other colleagues, John Roberts, have been doing lots of work sort of simulating their reports, which for a time are coming out every week, and publishing a summary of those on also from our Twitter account. And then towards the end of June, they'd amassed enough information to start doing some multifactorial analysis, because by nature of being intensive care, they're sort of looking at fairly low numbers, so it took some time to get up to the right volumes. And you can see there some sort of indication of their results. So quite interesting that for the socioeconomic effect, where again we look at the 5 quintiles, they were actually finding no difference for the first 4 quintiles, and then a sort of small but material difference for the 5th quintile. But partly I think because it's actually looking at mortality as opposed to the whole transition, also because it was looking at people already in intensive care, which is a somewhat different group from the overall sort of population of cases, or the overall population of potentially infected people. So that's sort of hopefully a sort of interesting sort of quick round trip through various multi-factor studies and what information it's given us about COVID-19 mortality and the sort of things we can use that for. So just rounding up then, I guess again the theme of the presentation is what have we learned, and clearly we've learned a lot about all that multi-factor stuff back in April, May. There's been relatively little published since, actually. So again, what we were thinking back in the summer is probably not much different from what we're thinking now, as concerns have moved on. And I guess what one concern is trying to sort of pictorially represent it here. What about modelling in respect of non-COVID-19 stuff? So going back to the point I mentioned back in end of February, early March, trying to think through what's going to happen if COVID-19 explodes and it's got a 1% infection fatality rate, then you'd have a sort of a death diagram where both of these blobs would be the same sort of size, but clearly due to the measures we've taken, we're now in the position of having far fewer COVID-19 worries, but much greater other worries. So one of the concerns, I guess, about modelling is it's not so much being too obsessed about COVID-19 in isolation, but thinking through what's going to happen in terms of all the other aspects. And I think that's particularly important. And probably one thing we sort of need to be thinking about more and more is if we're keeping COVID-19 under control with various measures, then what are the impacts of those measures on everything else? So obviously, we're sort of deliberately diminishing the economy for the sake of saving lives from COVID-19, but to what extent are we sort of properly modelling the impact of that? Because healthcare systems depend on having money to fund them, quite apart from some of the other sort of things which we have been quantifying, such as sort of deferred deaths due to delayed cancer screening and all that. So just to know that there's lots going on, or could be going on in the world outside the narrow remits of the modelling we've been talking about so far, just to probably leave us in an even more depressed state than before. Anyway, that's really all I wanted to say, and I hope we can type anything else in Q&A. So over to you, Louis. Thanks.
Thank you, Matthew. I'm Louis Rousseau. I work for Genry in my day job. I am responsible for research and analytics in Australia, Canada, UK, and South Africa. I think the Caribbean too, as well, actually. We're doing a lot of work on COVID-19, and I've done some sort of modelling, and I'm hope to bring a slight international twinge to this, to some of the work presented today. But I'll put a little asterisk there because I obviously don't have completely worldwide experience. But before I say anything more, I just want to put a disclaimer, and I love my disclaimer in the form of comics. This comic came out from XKCD early on in the epidemic. Somebody who's reading a lot of papers on COVID-19 and perhaps a lot of COVID Actuaries bulletins. And what he found out after all of this is that he figured out that the virus wants to get inside our cells, but he now knows it after reading all these papers with huge error bars. So lots of uncertainty in this topic, and it comes out when you start doing the modeling, and in terms of just how difficult it is to do modeling and how difficult it is to actually predict anything other than nowcasting. Almost and nowcasting is difficult enough, as Matthew mentioned. So the different angles I bring, hopefully I'm bringing some angles as a South African, part of the global south, coming from a lower middle income country, which has different, all the things that Matt Fletcher mentioned, has different impacts in terms of the data qualities and the way we interpret the data. South Africa is relatively advanced because we have a death registry. So many countries don't have a death registry, so that makes it easier. We have great researchers, but the data still is poor quality, but perhaps actually gives you a sense of, it's possible to get an inclination of countries where there's even less data, that possibly where to look out for some issues, which I'll touch on briefly. I've also got some experience in the HIV/AIDS committee and a keenness to get involved with new projects and things where we can make a difference as actuaries, and that's kind of why I got involved with this, and obviously some analytics modeling experience. In terms of the stuff that I want to cover, I want to first talk about estimating R. Just briefly, I think this has been covered very well by that COVID Actuaries response group, especially tracking admissions in the UK and seeing what the R is based on that. I kind of try to industrialize this process a little bit by focusing on all the data that's available around the world in COVID-19 and using that to estimate it sort of en masse. You'll see that you'll have links to some of the resources I present here on the right at the bottom right here. So you'll feel free to use those and look at those. What I'm doing there is I'm basically saying that infections today is essentially a function of infections in the past with some infectious curve applied. So this curve on the right here is the infectivity from the day you got infected. So maybe 5 or 6 days, 4 or 5, 6 days, you're at your most infectious. And if you apply that to past cases, and multiply that with R, you can estimate the infections today. Or to put it differently, if you reverse this process, you can estimate the R by looking at the cases today compared to the cases in the past, and perhaps doing some averaging over time just to smooth the results. We basically use this process to estimate the current reproduction number that we talked about. So remember, reproduction number is number of infections one person would generate going forward. This is just reversing that in a backwards looking way. You can, of course, infections, as Matt pointed out, is not known. So we would need to know, we would forward work of cases. And the assumption is that testing levels or reporting of cases is stable, which it obviously hasn't been. So that's something that you need to cast over or think about when looking at these figures. You can also estimate it from admissions, and that is obviously under the assumption that hospitalization rates are stable. And then also can estimate it from deaths, and that has the assumption that the IFR is stable. And you can clearly see that's already a bunch of question marks over estimates of R that you need to keep in mind when looking at the numbers. So how does the numbers look? These are just an overview of some of the numbers around the world, quite volatile in some of the countries with less data, but you can see clearly in the North America is having a problem, pink being R is above 1. So the whole of America, which is quite a large country, has an R above 1. Canada also has. Europe is kind of past the peak of its second wave as measured by cases, so they're on the green now. The number of new cases now is less than the number of new cases perhaps a week ago, which indicates that the R is below 1, which gives us an estimate, below 1 that we can see there. What we're seeing, some higher R's in the countries of the East, but these cases are very low and very unstable. So you would need to go and look at how many cases we're talking about there, and they're very low. I think an exception might be Mongolia. And then in Africa, there's also currently a problem. It hasn't been very high, but it seems to be slightly higher now, especially in Southern Africa and central Congo. Although the number of cases reported there are very low, and I would suspect that you need to go and dig into the quality of the data there, because I'm not sure that we have sufficient reporting in Africa on cases or deaths, and that I based on what we've seen in South Africa. So that's just extrapolating South Africa. So on the right, you get the estimates based on deaths, which are obviously show you the big gray areas where there's not enough data. Looking at a bit more detail into countries, what I've plotted here is an estimate based on the cases and an estimate based on the deaths. I have not shifted these estimates back, so what we'd expect is the estimates based on deaths to lag the estimates based on cases, and even the estimates of cases should lag the true underlying R. So they posted slightly differently, and I want to use this just to highlight some of the data issues you might see as well. So you can see US had a very high R initially, wide confidence intervals indicating that there was a few cases, but as the cases grew, it came down, and then they had their sort of first wave, a mini second wave, and perhaps a third wave now that we're clearly seeing now. But what luckily for the US is it seems to be that R trend is coming down on the country as a whole. Of course, with the US, you probably want to go and look at the different states and look at it in a bit more detail if you wanted to talk to US. And Canada, you can see fairly similar-ish picture perhaps, but a lot less cases, sort of lower infection rates there, which are not shown. But you can see the wave coming in. But you can see here on the estimates of deaths how there's a huge outlier there, and that is one of the artifacts of the data. A large number of late reported deaths were added to the counts in Ontario, I believe, and that resulted in huge cases there. South Africa has a very similar picture to the rest of the world. Our first wave did happen during some of our hardest lockdowns, but probably in the townships where it was difficult to lock down. And then what we see is we managed the epidemic, but South Africa recently has been seeing an increasing trend, which is quite concerning. Here's some more data issues. I think this sort of just highlights that the second wave in Europe seems to have been sort of stopped to some degree in Germany, Switzerland, and Poland. Sweden is always a contentious topic to talk about. You can see how high the R in Sweden was based on cases, and it seems to have suddenly decreased, right? But when we dig into the data, we do need to pay attention that Sweden is actually reporting their deaths and especially their deaths differently, because they are reporting by date of death, not by date of reporting. And this data set is most of the other countries are on date of reporting. So that means that there's actually an IBNR in these last weeks, which we need to allow for, which is not being allowed for. So that is interesting. Hopefully their case numbers are dropping because they are quite high for quite some time. And Switzerland is quite an interesting story where you can see they are shot up very quickly. I believe the story is that there was a yodeling contest in Switzerland, and that may have set off this sort of rapid increase in R. So that's sort of a funny story around that. So that's kind of just an idea of the kind of monitoring you can do with R and looking at cases, but that you need to bear in mind that the data isn't perfect, and it's very far from perfect. What I've done as well is done some modeling on Canada and South Africa, which I'm going to share with you now, mainly just to give you more of a sense of the kind of things to look out for and what there is. In Canada, I've used reported deaths as my target model, because remember, the cases are the levels of testing is very difficult to model, so the levels of testing has changed, so we need to look at deaths as our target outcome. And in South Africa, I've used excess deaths, because in South Africa, reported deaths is far below our excess deaths. It's a Bayesian model. It has is linked to mobility as well, and it's also linked to mask wearing legislation, not necessarily the actual mask wearing. There's also a weekly AR2 drift pattern, which is used. So my reproduction number is now modeled as a function of mobility, of mask wearing, and of this weekly error term, if you will, that is supposed to be capturing population behavior, but it's probably a general capturing of a lot of other errors in the model. And it uses then infection fatality rates, which are estimates, to predict deaths from the infections generated. So I'm just going to jump to how it looks. This at the top row, I'll show 2 provinces in Canada, just for interest, and the 2 bottom rows, 2 provinces in South Africa. I've chosen Ontario as the biggest province, and British Columbia, which shows a pretty increasing trend here. What you're seeing here in brown bars are the reported deaths in each of these provinces by day. The blue bars is my model's estimates of the reported deaths, or the estimate of the total deaths. What you can see in South Africa, maybe starting at the bottom left, is that my reported deaths are relatively close to my model deaths, and the model deaths are based on excess deaths, but it's still reasonably well above. That. Sorry, I forgot to mention that the blue areas are 95% and 50% confidence intervals. So clearly some underreporting in the Western Cape happening. In Eastern Cape, you can see during our first wave, very few of the excess deaths had been reported as COVID-19. We do believe that the majority of the excess deaths are COVID-19, and therefore that tells you just the story of how badly underreporting in a country like South Africa this could be. More recently, they seem to be tracking their second wave a lot better. So that is encouraging. And in Canada, we also saw the same. We can see that our reported deaths is exceeding the model at this point in time. I believe that this province, British Columbia, has had some underreporting of deaths in the past, and I believe that what we're seeing now is catch up from late reported deaths. So again, a data issue driving problems in modeling. These are just the number of infections now that we projected. You can see in South Africa, the number of infections far exceeding the case counts. In most periods, getting a little bit closer now, but the scales are just completely, the numbers aren't on the same scale. Canada doing much better in testing cases, estimated infections, and cases in brown bars are much closer together. And you can see potentially that also, because these numbers are so close, it actually shows us that potentially deaths are being underreported in British Columbia. This is now from the model, the estimates of the reproduction number. What you can see is this pattern of the reproduction number, which is kind of inherited from the error term, but as well as the mobility effect. So as mobility reduced in these provinces, you can see a sharp drop in R, and that's kind of the way in which the R is linked to mobility. You can see in Western Cape a drop when the mask wearing parameter kicks in. We started compulsory mask wearing in 1 May. You can see a drop there. You can similarly see it in Eastern Cape. In Eastern Cape, you can unfortunately see a wave actually going up during that, shortly after that introduction of mask wearing. So that is problematic for the Western Cape. But you can see British Columbia as well running, based on this model, estimating R at 1.5, which is quite high. The parameters that we've estimated in the model, I'm just going to give you a selection of those just to give you a sense of what it's doing. This is for Canada. This is by province as well. And what you see on the left is the implied percentage reduction in R, or reproduction number, if we were able to reduce average mobility by 100%. And you can see it's fairly sensitive to mobility in most provinces in Canada, in excess of 50%, with 2 provinces not being as sensitive. And on the right, you can see the impact of mask wearing in Canada. Now, this was modeled as a function of changes in legislation, sort of population weighted, and you can see that it's not as effective, or it's not estimated to be as effective in Canada, although there is a bit of a problem there because we're only looking at the actual legislation, and I believe people were wearing masks before the legislation kicked in, as opposed to South Africa, which had early legislation on mask wearing. In South Africa, this number is roughly 40% by province, and the mobility is less sensitive in South Africa, to give you a sense of what's that doing. So now I'm putting down projections here. You'll see a big star or big asterisk next to projections with lots of disclaimers at the bottom. So please keep those in mind. And those are only the ones that I could fit onto the slide. There are many more. And as George Box said, all models are wrong, but some are useful. And I do believe this model is wrong, but I hope it to be useful. What we're looking at, just to give you a sense of where different countries are. South Africa, the model is estimating between 20 and 36% infection rate to date. So that's we're getting closer to 40% of the population having already had COVID based on these estimates. In Canada, it's still very low, comparatively speaking. If we forecast to 31 December, when I set up that model, it seemed so far away, and we're actually just a month away. I just sort of think about now. We're looking at South Africa probably going to be closer to 35, touching on 50% potentially infection rates by the end of the year if current trends continue. But there's a big if there. If current trends continue, you saw the second wave starting. If the second wave doesn't get stopped, that is our destination with 80 or 90,000 deaths. We're currently sitting at just over 50,000 excess deaths in South Africa. For those who are interested. I think the UK was on 60,000. I'm not sure Canada is a lot lower at present. I don't have that number off the top of my head. Lots of parameter, lots of risk with these models. So please keep that in mind. The data limitation we touched on, simplistic models. This is a very simplistic model. IFR is a key parameter here and probably needs to be updated in some of my models. I think South Africa's are pretty high, 0.5% only, but we have a very low young population profile. So I think that has probably pushed down a little bit. And then Taleb et al., who really talk about it's not possible to do this kind of modeling because the mean is these distributions don't really have a stable mean, and so that's sort of a different angle on it, and that's something to keep in mind, that it's in a pandemic. The size of a pandemic is very difficult to predict because of the fatness of the tails in the situation. And he argues that we don't really need the modeling to make decisions. The fatness of the tail is enough to act quite conservatively and stop these epidemics, which I think is quite useful. Again, talking on uncertainty. So from what I'm learning as a professional in this space, there's lots of room for technical advancement. I learned a lot of new techniques, automation of processes, because all this modeling I had to automate because it's not my day job, all of it. And then also just thinking about the research on the systemic risk and really learning to weigh evidence better, because there's a lot of noise on COVID-19, and learning to weigh that evidence properly is a skill, and I'm still learning that. And professionally, I think it's a great opportunity to act in the public interest, and to really get some passion going on public interest topics, which are a bit closer to actuarial science than, say, the typical topics, and then allowing for different opinions and really considering the massive amount of uncertainty in this space is really important. I still believe, though, to end of my talk, I still believe that some of the best predictions remain relevant. This was a tweet I saw on 1 Feb 2020. Duct tape your underpants, 2020 is going to be a wild ride. I think that still remains, for me at least, one of the best predictions for this year and possibly for next year and the future still. Thanks.
Thank you very much, Louis. If we could move on to the next slide, please. I'll take things from here. I'm Stuart MacDonald. I am Head of Demographic Assumptions and Methodology at Lloyds Banking Group. So in my day job, I'm responsible for understanding the rates of mortality, so death rates and sickness, as well as aspects of customer behavior, like how likely people are to lapse particular products. I run a multidisciplinary team with actuaries, other statisticians, epidemiologists, medical research, and We also work closely with behavioral economists and data scientists in other part of the organisation. As Matthew mentioned, early this year, I co-founded the COVID-19 Actuaries Response Group with Hans Huischer, who's now the president of the Institute and Faculty of Actuaries. And I co-steer the group now with Matthew and with Nicola Oliver. The others have talked about aspects of modelling in some detail. So calculation of R, the transmission rate, calculation of fatality rates, and some of the early work that that was uncovered, and some of what's come to light in successive months. I'm going to talk a little bit about communication of results and use of the results, and really actuaries in particular, but also other groups are finding themselves, groups of scientists, communicating far more widely than their usual stakeholder base. So in my normal world, I would be communicating to insurance executives and board members, and you know, we're now in a situation where we're communicating to other scientists who may have different terminology for the same points. We're communicating with politicians who may not be scientific or technical in their background, and increasingly we are communicating with the media and with the general public. And there's important lessons there, and I'm just going to walk through some examples of where that's not gone so well this year, and I don't have all the answers for what could have been done differently, but they're things that I think we need to keep in mind when communicating the outputs of models. So if we go on to the first slide, we'll use a really well-known example from March. So this is from the renowned and infamous Imperial College paper on non-pharmaceutical interventions. So produced in March 2020 and very influential in this is an example of what I might hold up as scenarios versus forecasts. So it should be very clear to anybody looking at that chart that these are a number of different scenarios. There's no probability here for which is the most likely to happen, or you know, or any such statements. This is just one set of scenarios. So the paper had a number of what it described as suppression scenarios, and those aren't shown here, but those were the impacts that could have been expected under quite strong social distancing measures, non-pharmaceutical interventions such as the lockdowns that we eventually experienced in many parts of the world. But also shown here are various what were called mitigation strategies, ranging from do nothing, and that doesn't just mean the government does nothing, that also means the population does nothing, through to you know, the strongest interventions shown here, where all cases are isolated, individuals were asked to quarantine at home when they've identified as having caught the virus, and strong social distancing of the over 70s, so what went on to be called shielding. So, you know, one of the lessons here is that once a decision has been made, there is really no counterfactual that allows us to know for sure what would have happened under different circumstances. And we've seen that persistently in the UK, where this black do nothing line, you know, many of you will remember this was one that was forecast to result in between 400,000 and 550,000 deaths. And does that pass the sense check? You know, does that smell like it's a bad number? Well, not really. We were being given infection fatality rates of around 1%, as estimates coming out of China, as has been discussed. 1% of the UK population takes you to around 600,000. So that, you know, that does feel like a ballpark right result from a do nothing scenario if the the spread had been fairly substantial, and the fatality rate was as had been documented. And this still gets held up as an example in the press, on social media and elsewhere of scaremongering, and you know, you'll see assertions that the experience of other countries like Sweden actually disproves this, but I'd argue that it doesn't. The Swedes didn't do nothing. Case isolation was mandatory. Social distancing was strongly encouraged. Public events were banned. There was a partial school closure, so older school children. And you know, so if we're going to hold up a counterfactual from this chart, it's probably closer to the blue line, which had deaths around half of that do nothing scenario. But I guess the key lesson for here is that you know, these worst scenarios, and there is a risk that the people, the media in particular, may focus on the most extreme scenario, you know, as has been the case in some of the coverage of this paper. If we move on to the next slide, this is another early example. And this one I would hold up as an example about communicating uncertainty. So this was a paper that came from Sunetra Gupta's group at Oxford. So experimental epidemiology. Not everybody within the academic and epidemiological community would necessarily agree with all of the ideas of that group or that individual, but a credible individual nonetheless, and a study that set out to highlight, if we're to believe, you know, what's been said after the fact, to highlight the uncertainty that we were working with at the time. So case fatality rates were known, of course. We knew how many official cases and official deaths we had. Sorry, somebody's messing around on the Zoom. If we could stick with the slides, thank you. So the work rests on an assumption that the proportion of there was an unknown proportion of the population who were vulnerable to contracting severe disease. And what the group did is they looked at parameters of between 0.1%, so 1 in 1,000, and 10%, so 1 in 10. They didn't justify those choices. They didn't set out to. They just essentially said, look, not everybody has the characteristics that mean they're at risk of a very severe form of the disease that may go on to death. We can see that from the Chinese data that was emerging. So we'll assume only a minority of the population is susceptible. And then because we are working with the equation that Matthew showed you earlier for calculating an infection fatality rate, but we have too many unknowns to solve that equation, we will look at what the infected population has to be under these different circumstances to give us the observed number of deaths that we have seen. So they worked through this process and they established that up to half, under some very extreme assumptions of the UK, could be shown to have been already infected. Now, I would argue and the COVID-19 Actuaries response group put out a response to this paper that actually the scenario that shows up to half was entirely implausible. So for only 1 in 1,000 to be vulnerable to the risk of extreme, you know, of a severe form of the disease seems highly improbable. If you look at the UK over 65 population, around 1 in 5 have heart disease, a similar number have chronic obstructive pulmonary disease. So, you know, that was a really extreme example, and it ought to have been obvious to the authors that it wasn't plausible, because their same model implied that 80% of all of Italy had been infected. And just looking at the incredibly strong differences in the fatalities observed in the Lombardy region compared to the rest of Italy should have made it clear that the infections there were very significantly higher than elsewhere. So yeah, a number of reasons why the study perhaps ought not to have focused on such extremes, but ultimately there was an issue here in terms of how this was communicated to the media, and And again, a focus when writing headlines, even where some of the articles were more balanced, on the extreme outcome scenarios from the model, rather than necessarily the core result that was looking to be communicated by the scientists. And this is an example of scientists perhaps being less experienced, talking to the media, and not necessarily using the sort of language that might be suitable in a scientific journal, but not necessarily adapting it to make sure that the key message about uncertainty landed. So if we move on to the next slide, another early example from March, and this is an example, I would guess, of somebody with mathematical expertise, but perhaps not the domain expertise. So this was a study that came out of the engineering department at Imperial College London, and a forecast made that there would be just 5,700 deaths in the UK from coronavirus. And there's another couple of learning points here. So one was this was clearly a ridiculous prediction, and it was shown to be wrong just a couple of days later when numbers powered through. So, one was a naive application of the impacts of the Chinese lockdown to a situation where they wouldn't apply. So essentially applying the maths without giving any sort of common sense thought into the application and whether the circumstances were similar and relevant. But also, I would say this is a good example of false equivalence being drawn between different groups in a debate or a discussion. So the media were holding this up as being equivalent to the work being done by the infectious disease modelers in another part of Imperial College London. And in fact, there was one article early on, which I think got corrected, which even suggested that it was the same group and that they'd changed their mind and gone from talking about 500,000 deaths to talking about 5,000 deaths. So, again, it's all relevant to the context that we were operating in, a lot of uncertainty, a lot of new information becoming available. So again, this is one that we were quick to face into, and as soon as we became aware of this study, we put out a bulletin explaining why we felt that it was inappropriate, and sure enough, within a day or two that was shown to be the case. If we could move on to the next slide. So the comorbidity question. So this is one that's come up a lot during the whole debate and discussion. The deaths they were old and they had comorbidities. Well, that's not two different points. That's just the same point twice. By the age of 65, the majority of people have got two or more comorbidities. By the time you start talking about a population in their 80s, well, 80% of them have got two or more. That's what the chart at the top is showing you, is the proportion of different socioeconomic groups that have two or more comorbidities. And so a piece of work that Matthew and I did early on was to look at the life expectancies of different groups. So we took an obese male smoker. So that's a subset of the population which already doesn't have a great life expectancy. If you're obese, you have a shorter life expectancy. If you're male, you have a shorter life expectancy. For females, smokers, shorter life expectancy than non-smokers, obviously. And we tried throwing different diseases at them. So what if that person's also got type 2 diabetes? What if they've also got heart disease? And as you can see here, you're still left with a very significant life expectancy. So at age 80, your obese male smoker that's got type 2 diabetes still has 3 to 5 years left to live. So, this idea, this false narrative that there were people that were at death's door that were going to die in the very near future anyway, was certainly not the case in the main. I guess a learning point over time is that there are different populations, and certainly when in the UK, also in the USA and Sweden and a couple of other places where unfortunately the disease got into care homes, well then obviously you're talking about a very different population that perhaps only do have 12 months, 18 months left to live. But in the main, we're seeing groups with significantly longer life expectancies affected, and this hasn't gone away today. We're still seeing, I won't get into the complexities of life expectancy, but we're still seeing people looking at the average age at death and saying, well, that is older than life expectancy. And what they mean is period life expectancy at birth, which is the wrong number to use. And they're saying, oh, well, the people that are dying are older than life expectancy. So QED, they were bound to die soon anyway. It's completely wrong. But it is, you know, it's been a very difficult line of thought to combat. So if we move on to the next slide, as I say here, it can happen to the best of us. So this is a slide produced by Professor David Spiegelhalter, who literally wrote the book on risk communication. What this is intending to show is that your risk of dying after infection with the virus is similar to your background risk of dying. It's a really, really interesting result. It certainly wasn't inevitable. If we look at the Spanish flu pandemic, it was causing significant mortality in a much younger group. You know, there was no foregone conclusion that your risk would somehow be proportional to your normal risk. So this is showing you both normal risk of dying, very familiar to actuaries. It's on a log scale because it needs to be, because the risk goes up so quickly. It's roughly doubling every 7 years. And it's also showing the risk from coronavirus. But this was not written up well, including by the BBC and others. And it did lead to a widely held view that what the professor was actually saying was that COVID-19 wasn't increasing risk. So he was trying to show that it doubled risk. And again, this goes back to our infection fatality rate of 1%, the initial early estimate, which again, he would have been working with, he was working with slightly more up-to-date data, but, and it's worth saying and reiterating that infection fatality rate varies a lot depending on the age structure of your population. But, you know, a rough doubling of the risk, so a rough doubling of the number of people dying, is essentially what he was trying to show with this. That's assuming everybody got infected, of course. You know, but actually it was interpreted as there won't be any more deaths. So, you know, a wide misinterpretation. And of course, he went out and corrected that and wrote blogs about how that wasn't what he was trying to say. And of course, those corrections and retractions didn't get anywhere near the airtime as the original misunderstanding. So, you know, again, something that we need to be aware of. If we move on, how much have things progressed in terms of scenarios versus predictions? Well, not a lot, I would say. The second wave is progressing eerily like the first. Recently, as the UK's Chief Medical Officer and Chief Scientific Officer showed a scenario illustrating what would happen if doubling continued at roughly the rate that we were experiencing in early September. So again, we've got no counterfactual. You know, they were telling us this to essentially justify actions that they hoped would prevent this. But we don't know what would have happened had we not taken those actions. So social distancing measures were applied, infections fell, but we can't comprehensively prove cause and effect. Areas with the strongest measures, so tier 3, as we called it in the UK, and then, you know, we've gone on to apply lockdown. So those areas that had the strongest measures experienced the greatest deceleration and then the fall in infection numbers. So one take would be that the stronger control measures produce a stronger effect and reduce transmission more and so on. But of course, somebody else could argue that you know, those were the places that had the highest number of infections. Therefore, they're further along on their path to herd immunity, and maybe that's what's playing out. Now, that's not my view, but that is a view, and it's not one that I can disprove easily with the numbers and the mathematics and evidence that's available to me. So if we move on to the next slide, this one is slightly lighthearted, but you know, I've just set out using Matt's mortality curve from earlier, a bit of a timeline of the pandemic and some of the things that we've been hearing, some of which I've tried to address here. You know, from it's only the flu, well, you know, we've shown that the fatality rates are a multiple higher, maybe 10 times higher. They were at death's door. Well, as I've discussed, you know, that's not the case. It's clearly not the case that everybody dying is or was. We've seen various assertions that everything was going to be back to normal by June, August, September, the winter. And now the hope is that everything's back to normal by the spring. And, you know, perhaps the vaccine does mean that we will be on the path back to normal. We've seen recent discussion about false positives, about case-demics, about people claiming that there's no excess deaths. And as you can see, as you look towards the right-hand chart, and this is a fully age standardized and population standardized chart, we are back in the realm of excess deaths, unfortunately, at present. Some comments on this stuff. Firstly, the COVID-19 Actuaries Response Group has tried to remain objective, impartial. We're not promoting bad news or good news, or we're trying not to take a position. It is right that there is considered debate. We're trying to be clear on the limits of what we're able to discern from the data. We try to engage in good faith discussion where we feel that is a productive thing to do. There do seem to be some locked in and highly polarized views, and we've had criticism from both poles. There is also significant misinformation out there, and it can be tempting to give a lot of time and focus to that. And I've worn myself down trying to deal with it in the past, but actually, I don't think that misinformation is really cutting through to the majority of the public. If I do the mum test and speak to older relatives that are in the more at-risk group about some of the misinformation I'm seeing, and my concerns that the people that are spreading it have much larger platforms than I do, well, actually, it's still not cutting through. They're generally not aware of that, and are generally more informed by official messages coming from the government through mainstream media and what they're hearing from other sources. So I'm conscious of time. I'm sure that there are interesting questions for the other panelists and myself. So I think I'll pause there.
Thank you, Stuart. Thank you all the presenters as well. We have about just over 5 minutes of questions left, and there's definitely been some interesting questions. We've tried to answer them as we went along as well, so hopefully that works. And obviously we'll be sharing the slides and the recording with people afterwards as well. Maybe one of the ones that hit home with me was whether relapse has been used in the modelling as well. And particularly where that hit home with me, and Matt, maybe this is one that you could answer, is looking forward, including vaccines and the challenges into the modelling that comes of that as well. Don't know if you had any comments on that.
So I think, yeah, that's an interesting one. So I think my schematic that I put up was deliberately fairly simplistic, and it just modelled the states and transitions between them, just showed how it might generally go through. The issue of reinfection is an interesting one. My understanding is it hasn't been seen in more than a handful of cases confirmed as yet, but long term, whether people are subject to reinfection over the longer term is definitely a significant unknown. And again, obviously that will have, if you can get infected again in relatively short order, that will have big implications on future spread, future potential lockdowns, how vaccination works, and how often you will need to be vaccinated. So I think that is a key question. I think that the initial work that is going into it, and the results that are coming out look relatively positive as far as I'm aware on reinfection over the shorter term, but it's certainly an unknown, and certainly something that in models I would expect people will be considering and putting in as at least as a sensitivity to show what happens if you can get infected again within 6 months, a year of being infected the first time.
Thanks, Matt. The other one that came through elsewhere for me was this is very fast evolving and very different level of pace compared to what actuaries are used to. Maybe this is just a general question to the panel. Our traditional challenges is in annual reviews and annual analyses. Were there any specific challenges that you were faced in overcoming, and how did you go about it to do this?
Yeah, I think you're absolutely right. It's been a real challenge to respond quickly, and it's a debate and discussion that was live right from the start, and even plays to why we set up the COVID-19 Actuaries Response Group. You know, it's a separate group outside of the Institute and Faculty of Actuaries, and it, you know, has been, because we wanted to do the best we could do and produce work that wouldn't necessarily go through the usual extensive peer review, you know, consider every angle, be as thorough and meticulous as you would expect of our profession, but perhaps not necessarily be timely. You know, this situation has called for rapid responses on a best endeavors basis, and we have always tried to be very clear in our communications when we're doing that. And as I talked about earlier, the extent of what we can and can't know. And you know, we've accepted that some of our material might be shown to be incorrect with the passage of time. We've actually had a remarkable success rate, and we haven't had to pull any bulletins or amend anything of substance. But that wasn't inevitably going to be the case. We've been operating at some risk here, and we've always tried to be clear about that.
I can perhaps add, just from South Africa, I was involved with the HIV/AIDS committee that was responsible for was managing and maintaining the HIV/AIDS model and all the work around that. And I can certainly confirm that the pace at which we need to work now compared to that is tremendously. So the same level of uncertainty, but just that kind of level of uncertainty together with the pace of, say, the HIV/AIDS work in South Africa is very different.
Yeah. Next question then. Given the good work coming out of the COVID ARG, can we expect some definitions and best practices from you guys, or have you published something already along those lines? I would take that as a no. Maybe
no,
given
it's
that...
an interesting question. I could see that as being helpful. I did consider doing something similar earlier on about the difference between a case fatality rate, an infection fatality rate, a mortality rate, and a population fatality rate, and all these different definitions, which to an untrained eye might appear to be very, very similar. We haven't produced something comprehensive that does that. I have shared other material where people have attempted to do that, but yeah, let us think about whether that would be a useful thing to do, and how we might share that.
Thanks, Stuart. And then one last question, Matthew, maybe this one is for you. Can you outline what else is going on in the actuarial profession that might be of useful to the audience?
Yeah, sure. That's a good question. That's actually, we're very, very proud of what we've done within the COVID-19 ARG, and hopefully lots of our output have been of use to many people. And we obviously, as Stuart was saying, sort of set up in a sort of what we think is a very slick and pragmatic way. There's lots of other stuff going on in the profession. So I think partly spurred on by the way we'd got going with the ARG. The Institute and faculty then set up the ICAT under Colin Duckovitz, which is producing more and more sort of working papers and so on. So that's all been good stuff. The other sort of two things I wanted to note, because I'm more involved in them, are the CMI, the continuous mortality investigation. So many of you hopefully are aware of the CMI and all that we do. And we've been doing two big things this year. One is the mortality monitoring, so comparing deaths this year against last year. So not so much trying to sort of do any sort of pandemic projections into the future, anything like that, but more just saying this is what we can reasonably infer from data to day, because CMI is very data driven. So that's been hopefully very useful. And also we set up a COVID-19 working party, and that's produced stuff a month or so ago, and that's all public domain, in fact 2 months ago. It's on the IFOA website, and it's just setting out issues for assumption setting people to sort of think about. So that's one strand. And then the other strand is a bit of a plug, because I'm also involved in the longevity bulletin, which is the IFOA's main sort of longevity annual twice-a-year publication. So we're just coming up with the COVID-19 issue of that on Monday. So if you check the IFOA website on Monday, we'll have a hopefully a very interesting publication for you all to read with covering many of these aspects. Many of the articles written by members of our group. So if that's not too commercial, it's all free.
Thank you, Matthew. I'll wrap it up there. From both IAA and NOCA, gentlemen, thank you very much for all the good work and for the very interesting presentation. To all our participants and attendees as well, thank you for attending today. And please keep an eye out for the next set of sessions that we're going to be hosting. We'll start promoting those shortly, and see you all in December. Thank you very much. Stay safe.
Thanks. Bye.
Thank you. Bye.